because you don't know that you have it to be able to use those technologies and approaches. So again, we can turn, spin, rotate that blood vessel. We can also then take that vessel here, and now with the magic of computers in this window, we're basically straightening that vessel out. And what we can do is this allows me the ability to turn and spin, rotate around that blood vessel, so you can see that plaque here. And you can actually see, it's a little subtle here, but you can actually see, and I'm going to zoom up on that blood vessel, this gives me the cross-section anywhere along this blood vessel. So in fact, what I can do with this blood vessel is I can literally, as we might in a microscopy, histopathology lab or autopsy lab, we'd take that artery post-mortem, right, and we'd chop it up and we'd see where there's plaque. Well, we can now do that before that occurs
before
here.
You die. So said in English, if you were a stiff, we could take you, pull that artery out, lay it down, chop it up in little pieces, and
which
look
would tell
at
us
it.
the answer, but a little too late.
Yeah, got it.
So here, this is the cross-section here, and you can see now we're beginning to hit plaque.
Yeah.
And note, but that plaque is out here in the wall.
So is this dark spot right here early plaque,
Yep.
and the white stuff is old
it's
plaque?
a mixture of some plaque. But note the channel here, particularly at this location, as we cut directly through that blood vessel, that's the cross-section here. These are the cross-sections 1 and 2 millimeters downstream, and the cross-sections 1 and 2 millimeters upstream. Looks just like that. So what we're seeing is just like our model. This is plaque that's grown outward. There's no blockage, there's no obstruction, but there's a significant amount of plaque there. But also we can characterize the plaque at that location. It's a calcified plaque that's relatively stable. It's more like cement. As we move further down this blood vessel, we leave the calcified plaque, and now we're heading into the new plaque. And you can see here, what's amazing, this white is the channel or the lumen. All this stuff out here, this gray stuff, is how big the vessel used to be, and all of that is lipid or cholesterol.
Wow.
So this really gives us an incredible view of
You have
this
some way of
process.
making this color look that color. How do you do that? No, making this look that color is what I'm trying to say.
Oh, we can also turn on this window. This is what
There
we
you
call, we use a tool in the cath lab, an invasive tool, we don't have to do that anymore, called virtual IVUS. So what this means is we can take all this data and then convert it to this image here, where we could basically, if we were to translate all this to a three-dimensional view, we were to shrink ourselves and do the fantastic voyage in our little microscopic submarine down the coronary artery, that's what it would look like.
Okay, so go slowly here for one. Could you go back to the beginning, and let's go slowly to make sure that people understand what you're saying. You have vascular biology, which is the outside of this, and luminology, which is the inside.
Right.
So the fantastic voyage is, whereas if you go to a cath lab and you have a cath done, all they get to look at is what's inside the circle.
That's all I
But
can see.
what you can look at with your CTA is the circle and the donut,
right? So when we used to do angiograms or heart catheterizations, the limitation is, particularly because of how the plaque grows, if I did an angiogram on this blood vessel and this one, with plaque out here in the wall, did an angiogram on that blood vessel and that blood vessel,
they look the same.
They're exactly the same. I couldn't tell, and I'd say they're both normal. In fact, when we used to angiograms, I would always carefully say, because we knew that this was the case, that it is angiographically normal, which means the channels are okay, but I have no idea if you got plaque like that out here. By the time you get to here, most of the times we'll detect that on an angiogram as long as we have sufficient views. And down here is when we flunk our stress test.
Yeah.
And have chest pain.
Got it.
And here you can see the channel, and then this is all the plaque out here.
Okay, so let's just focus on the circle, and then take us on the virtual donut tour here.
And then here, as we get into normal vessel, you can see that the wall is nice and thin, and there's the channel or the lumen.
Wow.
Now the other thing that we can see here, and I'm going to turn this off here for a moment, is that this, remember that this whole blood vessel literally expands and gets bigger, and that's what we're seeing here. So we're actually seeing an expansion of that plaque going outward at this point. That's why this person has no symptoms, no chest pain, and had a normal stress test. In fact, the first time we met this gentleman, we did the first scan, this plaque was much worse.
So you've actually regressed the plaque. You've made the plaque better.
This is now 18 months later. He'd had a normal stress test 6 months before he had the scan, and he felt, I'm great, I'm in perfect health, I have no issues. We did this, and we both realized he's got an issue.
This is
we then aggressively treated him, and what we're seeing now, 18 months later, with optimal numbers and blood pressure and cholesterol, et cetera, we're literally watching this plaque reverse. The first study we did, this was about a 60 or 70% blockage. Now we're down about 40% in the span of 18 months. And appreciate this thing's been growing there for decades.
So why would you not take that person to the cath lab and put a stent in, or
well, you know, we know now that in ballooning things and stenting things and opening things up and bypassing things is really good to treat symptoms when you got a severe blockage. At this point, we caught it before he had a severe blockage, and he doesn't need us to do invasive procedures or put in $3,000 worth of metal to open and prop open that blood vessel, because it's still adequate to deliver enough blood flow. What we need to do, because when we balloon things and stent things and bypass these vessels, it doesn't treat the condition, it doesn't treat the disease, it doesn't treat atherosclerosis or plaque. It pushes things off the side or bypasses around it. So for this gentleman, and he's actually had 2 stress tests now, because of the first test, we were really concerned. We did another stress test, making sure there was absolutely no evidence that there was a restriction of blood flow, and there was not. He had 2 normal stress tests. When we can, with that understanding, opening that blood vessel would not buy him any benefit. But treating this aggressively would actually treat the plaque, and we can actually help to reverse it.
And what did you use to treat him?
So we actually used a combination of beyond diet and exercise, an aspirin a day. We gave him some fish oil, omega-3 fatty acids, and we also gave him a statin to lower the bad cholesterol, because his bad cholesterol was still high, and his HDL, the good cholesterol, was low, so we actually gave him niacin, or a pharmacologic preparation called niaspan.
Wow.
And with that, his numbers changed dramatically, and he went from plaque forming to plaque regressing.
Amazing. Now, what's the chance that that still breaks open and he has a heart attack?
You know, when we begin to see this process and see these plaques regress like that, that falls dramatically.
So it's kind of, it's like there's pressure inside of it that's building it,
right.
And then the second you turn that around, it's like,
right.
It starts to feel better.
Yep.
Got it.
So this is how we actually look at all the blood vessels. We're just focusing on this one blood vessel, but we go through all the different blood vessels. There's little branches of this major blood vessel here. There's 3 major blood vessels that go to the heart, and we look at all of those. Now, he was fortunate that this disease tends to be spotty. It tends to be sort of isolated in different vessels in different spotty areas, but the rest of his vessels look pretty good. In this blood vessel in the back part of the heart, you can see he does have another, exactly. See, you're good.
I'm getting there.
Yeah. So here, he does have some other plaque here. Again, this is stuff that is in the wall. You can see here, it's growing outward. If I did an angiogram on this blood vessel, couldn't see it.
Nope.
Couldn't even see it. I wouldn't be able to say, gosh, do you have plaque or not?
That's amazing.
And then here, again, you can see literally the vessel's gotten bigger. He's got some calcified plaque here. This is not the kind of plaque I'm worried about. And as we treat the plaque elsewhere, all the plaque everywhere, both in the heart, in fact, everywhere else in the body will get better too.
Wow.
So fortunately for him, the real hot spot is that area right here.
And it's one you're treating and following, and
yep.
So will you do another one of these scans once a year to make sure it keeps getting small?
It depends upon the burden of the plaque, how much cholesterol-rich plaque they have, and all that. In him, I was really worried both because of the size of this vessel, the location, how much cholesterol plaque he had there, all the characteristics of a vulnerable plaque, the kind that ruptures. In him, we kind of did more frequent